All right, today's lecture is on Facet syndrome, anatomy, physiology, and pathogenesis, or the origin and development of Facet syndrome. Guess what? There is no lumbar Facet syndrome. Wow, shocker. It's not semantics. A syndrome is a clinical entity defined by a specific constellation of clinical features. For example, Reiter syndrome or reactive arthritis syndrome. In order to have that syndrome, you must have urethritis, uveitis, and spondyloarthropathy. There is no predictable combination of clinical features that actually defines lumbar facet syndrome. What are we saying here? There's no subjective, right? There's nothing the patient can tell us. And there's no objective. There's nothing we can find on the patient that would actually differentiate zygapophyseal joint pain or facet pain from any other pain emanating from the lumbar spine. There is no test, no orthopedic test that would clearly differentiate that a patient has facet-oriented pain or a facet syndrome. If you think about it, like if you're thinking Kemp's, well, turn and bend obliquely backward and think about how many structures are being compressed when you do that. Your SI joint is in a bind, it's being compressed. The facet certainly is, the posterior margin of the disc is, the interspinous ligament is, all the small intricate muscles of the lumbar spine are. So pain emanating from any of those structures would be perceived in an identical fashion by your brain. And no surprise, all of those are innervated by the same segmental innervation, the medial branch of the dorsal ramus. Therefore, they're all going to produce very similar pain, indistinguishable from tissue to tissue. So when a patient has pain that might be emanating from a facet, it is more properly termed lumbar zygapophyseal joint pain. Nonetheless, we'll refer to it as facet syndrome. And by the way, there is no ICD-10 code for facet syndrome. So here's a very interesting study. What did they try to do? They wanted to determine the prevalence and the features of pain stemming from the Z joints. Prevalence, out of 100 people with back pain, how many have it emanating from the Z joints? Clinical features, nature of the pain, quality of the pain, so on and so forth. So they took 176 patients with chronic low back pain. They had to have no history of surgery and no positive neurologic signs. When you have positive neuros, you start to bring the disc in. They did a short-term block, what they called a screening block. They anesthetized the lower lumbar facet joints, and then they had a grading system. Are you now worse? No change at all. Partial improvement, definite improvement, complete improvement. So those who have obtained the last two, the definite or complete, they stayed in the study. They came back in 2 weeks and they got a long-term, stronger anesthetization of the lower facets, what they call a confirmatory block. Let's show you the results. 47% out of that original 176 had the definite or complete. That eliminated 93. 15% of the remaining had a 50% or greater response to that confirmatory block. That eliminated another 71. So out of the original 176, that left 12, or approximately 15%. What did the study confirm? It confirmed what previous research had already indicated, and that is that there are no clinical features that discriminate between Z-joint pain and pain from other sources. This was an interesting finding here. No patients with central lower back pain responded to the Z-joints. Why do you think that is? Well, the answer is central or axial lower back pain is typically discal. And of course, if you anesthetize the facets, it's not going to do anything to the sinovertebral nerve and back pain of discal origin. So the Z-joint or the Z-joints are a source of lower back pain in a minority of chronic low back patients. The prevalence is still uncertain, 15% maybe. There's other researchers that say more, some say less. And the existence of a Facet syndrome is questionable. And you cannot have a syndrome until you have a clear constellation of clinical features that's expressed across the board and across a population of back pain sufferers. Oddly enough, although there is no such thing as a disc syndrome or an HNP syndrome, herniated nucleus pulposus, there should be. Because what you see on your screen, if you have 3 out of those 5, you got a disc. Interesting. All right, what do Z-joints do? Well, they direct segmental motion, but they also constrain it. Think about it. In the lumbar spine, we have sagittal facets, so they're pretty much directing movement in a flexion and an extension pattern or mode, but they constrain movement also. They obviously limit rotation. As we've learned, you have about 2 to 3 degrees of facet-based rotation in each direction. They play a very important role in protecting the disc against excessive torsion, and they provide mechanical stability to the functional spinal unit and the spine as a whole. 78% of stability of the spine comes from the posterior column or the facets, 22% from the anterior column or the discs. All right, so it's really hard to differentiate posterior column pain. Matter of fact, not only is it really hard, it's downright impossible. When someone comes in with localized garden variety nociceptive back pain, it's about impossible to determine exactly which pathoanatomic structure it's coming from. Here's an example. If we take the area, a circular area the size of a silver dollar, and put it over the PSIS, which is a really common point of pain. Let's see what's there. Well, of course we have the PSIS. We've got the right Z joint. Yeah, here it is. Right there, it just came up. We got the sacrospinalis tendon. It just came up on that same diagram. We've got the right posterolateral margin of the L5 disc. It just came up on that picture. We've got the right SI joint. And we've got the origin of the gluteal musculature, all in that little silver dollar area. Very hard to differentiate which one of those the pain is coming from, although there's no reason not to try. You certainly can do aggressive palpation of the SI joint and see if there's any tenderness, pain, inflammation, heat. And you can do SI joint oriented tests that might lead you to specific finding that it is SI involved. So we certainly do want to try our best. The only way to actually do that definitively is to anesthetize each tissue one at a time. So L, lumbar Z joint pain, discogenic pain, ligamentous, muscular, and sacroiliac pain all overlap. So, imaging, where does that come in? We do get certain information, but it cannot independently determine whether a particular structure is painful or even involved in the pain producing process. So don't let that get you down. You do your best, and whatever you say it is, doc, is what it is. If you tell the patient they have a sacrospinalis tendon strain, that's what it is. If you tell them they have a right sacroiliac joint instability, that's what it is. If you tell them they have concus of the bronchus, that's what it is. The beautiful thing about chiropractic is once we've made the diagnosis, we then follow our chiropractic technique roadmap, and it does a great job at helping our patients. Okay, so another example of overlapping tissue patterns or tissue pain patterns and the difficulty of subjective input from the patient in determining which tissues they come from. This could be any patient to the left, to the right, who says, Doc, I'm having pain in the front of my left thigh and into the back of my left thigh, right? Both of these would be evidence of that. That one and that one. They're certainly slightly different, but the patient's not going to tell you anything different than maybe that they'll put their hand here, or they might put their hand here, same thing, right? So, but look at the difference here. To the left, you have referred pain patterns from stimulation of the lumbar multifidi, right there, and here we have referred pain patterns from stimulation of the L4, L5Z joint. So again, overlapping pain patterns from two totally distinct anatomical structures in the lumbar spine who both have identical innervation, the medial branch of the dorsal ramus. All right, quick anatomy review. If you look at the center over here, you can see the beautiful roots of the cauda as they're descending. You can see the dura lining the back. You see a little fat pad there. You can see ligamentum flavum is thick, right? It's probably buckled or hypertrophied, right? Here's the articular cartilage here, and then you can see the joint itself. The facet capsule would have inserted over there. And then, of course, you've got your disc in the rear, which looks like it has some fissures in it and some circumferential tears and degenerative changes. All right. In terms of general anatomy, there's really only one thing I want to point out here because it's an important structure, and that is the meniscoids, or the synovial folds. If you look at the superior aspect under the capsule and over here at the inferior aspect by the capsule, those little black areas that are projecting down into the joint, erase that and that, those are your meniscoids, or your fibroadipose lubricating sponges that maintain a film of synovial fluid within the articular cartilage to, just keep them from wearing out. We'll discuss those in greater detail shortly. All right, here's some proposed etiologies of facet joint mediated pain, or pain stemming from the facets. There's 8 of them listed. Let's go over them one at a time. Number 1, capsular tears. Anything that would over-compress or overextend the joint can create a tear in the joint, and that's what's being visualized right there. That's a tear in the capsule. The red is inflammation and also the secretion of chemokines. Anytime there's soft tissue damage anywhere in the body, you have the secretion of chemokines, which are pro-inflammatory hormone-like mediators of inflammation. And so they are going to increase interstitial fluid in the area, which of course bathes the injured area and allows transport mechanism in and out. For nutrients in, new cells in, new collagens in, and then debris out, from injured, damaged cells. So chemokines do two things. They lower the firing threshold for activation of the nociceptors, so the area becomes very tender to the touch and painful. But they also stimulate angiogenesis or neovascularization, two synonyms. New blood vessel growth. New blood vessel growth helps to go in and restructure and heal the tissues. And then to the right here, that's a capsular sprain or capsular tear in the cervical spine. Capsular deformation. When you have degenerative disc disease, often you also get a posterior displacement of the vertebrae, just like you see in the picture. And when you do, you have a retrolisthesis. And you also get malposition of the facets. Malposition of the facets puts a stretch on the capsule, and that will stimulate the nociceptors in the area, causing Z-joint generated lower back pain. Number 3, capsular or synovial inflammation. Right? So one of the mechanisms for that would be mechanical disorder. So let's say you have a fixated Z-joint on the left. That would be that one right there. That one's just not moving or moving barely. This one here becomes hypermobile to compensate for it. And that hypermobility causes excessive wear and stretch and strain on the tissues, leading to capsular inflammation and stimulation of the local nociceptors, causing localized back pain. And that would be a right-sided back pain, or the patient may say, it kind of hurts in my back and I feel it more to the right side. All right, capsular avulsion and articular cartilage damage. This we've gone over before. This is the Farfan model, Farfan torsion model. I don't want to really spend too much time on this because we've already done that, but here the vertebrae is rotating body left, spinous right, and you can see the capsular avulsion or the capsular compression and the circumferential tears in the disc. And there's the model. I'm going to let you review that on your own because we've already done that with the previous lecture. That just goes over all the steps involved in a torsion injury to the disc and everything that occurs as a result of that excessive torsion. Articular microfractures, right? So that was just covered actually with the Farfan model, and those microfractures would occur right there on the compressed side of that torsion injury. And then our last lecture we discussed spearing. All right, remember that term, spearing, from hyperacceleration deceleration injury, where this articular process spears down right into that one. We'll be reviewing that again on our cervical spine lecture. I guess we're doing it now. Here we go. Okay, so this is the mechanism of cervical facet joint spearing. If you remember the instantaneous axis of rotation, or that point where cervical vertebrae flex and extend, is right here, right in red, right there. And then there's the arc of that flexion and extension, occurs around that arc. And that's like the spoke of a wheel, if that's an analogy for you. If we were to put a spoke right there, right, and there's our wheel, you can see that the wheel rotates around the spoke. That's the same way the vertebra does. Well, during an accident, that spoke shortens, that arc compresses, and the vertebrae spears like that. Of course, the black arrow is better than my red arrow, and that causes numerous type of injuries to the capsule, the cartilage, and the actual bony structures of the articular pillars themselves. Osteoarthritis is a questionable cause, although in some individuals it's definitely the source of their facet-mediated pain. In many it's not. Here's an article, 2014, Systematic Literature Review of Imaging Features of Spinal Degeneration in Asymptomatic Populations. There are many people who age, and as part of the aging process, you have disc degeneration, spondylosis, facet arthrosis, the whole mess, and these people basically are pain-free. So not always, but often. So you have to be careful with what you see on an x-ray. And oftentimes when you see a lot of degenerative arthritic changes, it doesn't mean that that's the source of their pain. Okay, off to capsular sprains and synovial impingement. That can occur from either hyperflexion, which is obviously going to stretch the capsule beyond its normal elastic limits and sprain it, or hyperextension, which could compress the capsule, or if the facets ride down, like we see in this picture here, it can also stretch or impinge the capsule. So either one of those injuries can cause a sprain to the synovial lining or to the capsule itself. All right, meniscoid entrapment or extrapment. So the top, or A, that is entrapment. And what's happening here is the articular pillars jam together and entrap the meniscoid and pinch it. This B is extrapment. Extrapment. That's where the meniscoid gets stuck in the superior aspect of the capsule, becomes a space-occupying lesion, generates pain and muscle spasm, and locks the facet down. That's your more common one right there. All right, a little bit more on these synovial folds or meniscoids, these synovial-lined extensions that come off of the capsule. They protrude into the joint space. They cover part of the cartilage, but they do assist, like a sponge, in the dispersal of synovial fluid. They lubricate the joint cavity. A few different descriptions by different authors. Meniscus, joint meniscoid, fibroadipose pad, intra-articular synovial fold. They vary in number, size, shape in different regions of the spine. They're found at all levels. They're well developed in the C-spine and the L-spine, and they are loaded with pain sense organs known as nociceptors, making them painful if compressed. All right, so here we have a diagram showing the meniscoid in the square. Here is a 10-time magnification of it, the arrow pointing to its tip, and here's a 40-time magnification of it. And you can see those little spaghetti-like features over here throughout this one. Those are all nociceptive pain sense organs. And there's a great micrograph, right? Microscopic slide showing somewhat in real time that meniscoid. You can see how it goes into the joint. And of course, it's going to act like a sponge and lubricate that joint. But you can see it's in a precarious position. It could easily get pinched or fold upon itself as facets open up during different movements. All right, so here is what is believed to be a common source of acute, simple, garden variety lower back pain. So here's somebody who maybe it's Sunday morning, they wake up out of bed, they kind of shuffle over to the front door, out to the front porch, bend over to pick up the newspaper, and yow, their back goes out on them. All right, so what happened? All right, let's take a look at the picture A to start with. Picture A. Right there. So this individual bends forward to pick up his newspaper, and the inferior articular process kind of separates or rides up on the superior articular process, and it takes the capsule with it, kind of stretches the capsule, and it takes the meniscus with it as well. All right, well then that same individual, now that he's got the paper in his hand, comes up, and as he comes up, what happens is that same inferior articular process now wants to glide down back into its normal position and take that meniscoid with it, but unfortunately, for whatever reasons, I call it the perfect storm, that meniscoid gets trapped. Boom! Immediate pain, immediate nociceptive afference up the cord into the cortex, telling that patient, yowza. Right? So all of a sudden he's in bad shape. He's now walking around bent forward, his back is in spasm, severe pain is emanating from that facet, probably central to right-sided back pain, and that facet is locked. So he gives you a call on a Sunday because he loves you. Doc, I threw my back out. And you say, because you're such a nice guy, meet me at the office, be there in 30 minutes. And you examine him, determine it was just a simple locked facet, and you put him on his side, crunch. That opens up the articular facets. It allows the meniscoid to settle back down in its normal position, and the patient goes, ah. They get off that side posture bench and start walking around, and they're like, oh man, thank you, doc. That's a lot better. I mean, it's still sore, but that's a lot better. That you're going to pay your student loans off with that, folks. That's a common malady that you will see daily. And it is also resolved through a wide myriad of different chiropractic procedures. An activator properly placed on that facet can do the same thing. Dropping, blocking, decompressing, they can all take care of it. Simple garden variety mechanical back pain from a locked facet with an entrapped meniscoid in it. Facet tropism, something to keep in mind. It can really fool you when it comes to palpation. I'll explain why in a second. It's most commonly found in the transitional areas of the spine, primarily found not in the lumbosacral area, primarily in the thoracolumbar, secondarily in the cervicothoracic, and tertiarily, if that's a word, in the lumbosacral area. And it can occur anywhere within the spine, folks. It's a genetic aberration. But when they're there, you have to be cautious against assuming that there's something abnormal with the joint when you palpate it, because it's going to palpate oddly. That spinous may gravitate more to one side than the other. So when you just do passive assessment of spinous process movement, you can be fooled. And remember, these occur in the transitional areas of the spine, and that's where a lot of people have their trouble and where we do a lot of palpating. So make sure that you know how to not just passively assess the joint, but that you know how to spring the joint. True motion palpation, where you can determine if the joint is functioning, not just moving a little bit more one side to the other, but actually functioning as it's supposed to. If you don't quite understand that concept, you will have to get with the Motion Palpation Club or take some seminars from the Motion Palpation Institute. All right, according to this author, facet tropism was correlated with disc degeneration, but not with facet joint degeneration. So when you definitely get a strain on the disc when you have a coronal facet on one side and a sagittal facet on the other side, as you see in the picture. But apparently it did not have a detrimental effect on the facet itself. All right, sensory nerve supply to the facets. If you remember, we mentioned it was the medial branch of the dorsal ramus. The dorsal ramus is also known as the posterior primary division, right? Every facet has triple innervation. So the posterior primary division above, at, and below the facet. So when they go in there to do a block, they have to make sure all of those are covered. It's a very pain-sensitive area of the spine, secondarily only to the disc.